Okay, good afternoon, everyone, and welcome to today's webinar looking at clinical and public health considerations in a time of COVID. So as you know, I'm Dr. Nisha Jacob, public health medicine specialist and currently convener of the Navigating COVID-19 short course with Professor Francois Cilliers. So on Friday, we had some fascinating insights into being a healthcare worker at a time of pandemic. And today we'll be looking in more detail at the provincial response to the pandemic as well as clinical considerations. So we're really privileged to have three excellent speakers today who have been extremely busy at the front lines of this pandemic, and we are most grateful to them for their time. So our format will be the same as Friday. Firstly, we will have presentations from our three speakers, Professor Graham Makeys, Associate Professor Marianne Davies, and Dr. Virginia Zwigenthal. And I will introduce each of our speakers before they present, and they will speak for approximately 10 to 15 minutes each. And during the webinar, you are welcome to send your questions via the Q&A function, and we will try to answer as many as possible within the discussion and via text or on Vula afterwards if we run out of time. And after each presentation, if time allows, we will have one or two questions of clarity. And at the end of the presentations, we will have a broader discussion, including your questions and reflections from our panelists. And today, our panelists lined up include the 6th year students, Danielle Hugo, Sibusisiwe Mangotya, and Christine van der Walt, who were involved in the case and contact tracing teams, Dr. Yamanya Tembo, a public health medicine registrar, and Dr. Karen Begg, who you all know well, public health medicine specialist and deputy dean for undergrad at the Faculty of Health Sciences. So I apologize that we started a little late, but without further ado, let me introduce you to our first speaker, Professor Graham Makeys, infectious diseases physician in the Department of Medicine at UCT and Groote Schuur Hospital. Over to you, Graham. Graham, if you could just unmute.
Okay, I'm just going to share my screen then. If you could give me permission for that.
You can share your screen, Graham.
Okay, thanks very much. So thanks very much, Nisha. You are hearing me, is that correct?
Yes, Graham, we can hear you.
Okay, thanks. Thanks for the invitation to speak and welcome to all the students and colleagues in the webinar today. So I've been asked to speak on the clinical features and management of COVID-19, and I'm going to restrict my talk to that topic and try and get through it in 10-15 minutes. It's obviously a very broad topic, and I've chosen some of the highlights to cover in the time available, and obviously can go into more detail in the discussion section. So what you're seeing in this first slide is the timeline of COVID-19. So from the point of infection with SARS-CoV-2 to the development of symptoms, the incubation period, that time period is on average 5 days. The incubation period, it can vary. It's been reported to be as short as 2 days, and really it can go up to 14 days, the incubation period, but that's really the tail is quite a limited number of people would have an incubation period longer than 7 or 8 days. When patients do develop symptoms in the blue block, the typical first symptoms that patients develop are fever and cough. It can also be a sore throat that's not listed there, fatigue, anorexia, myalgias like a flu-like illness, as well as diarrhea. What's also been reported as quite characteristic of COVID-19 is loss of taste and loss of smell. Now, most people will just develop those mild symptoms of a severe upper respiratory tract infection, but a subgroup of patients will go on to develop a viral pneumonia, and that actually happens quite a few days into the illness. On average, about 6 to 8 days from the onset of symptoms, patients start to experience a shortness of breath. And in this one report, that this data is based on 40% of patients with COVID develop dyspnea or shortness of breath. And then an even smaller group of patients will develop severe illness, where they require intensive oxygen support, and 5% will develop critical illness, essentially requiring ICU support. So that's just in terms of the timelines. Just to emphasize that there is a group of people that develop infection with SARS-CoV-2 that remain asymptomatic, and across different studies that the proportion of patients who are asymptomatic varies quite widely, but when you pull the different data together, the average is around 16% of people will develop infection but remain asymptomatic. This timeline, very similar to what I showed you, but just putting on different labels. Here the authors divided the progression of COVID-19 into 3 stages. Stage 1, early infection, stage 2, the pulmonary or pneumonia phase, and stage 3, when patients develop what's called the hyperinflammation stage, where they develop multi-system disease and features of severe systemic inflammation. Just to say that this is probably an oversimplification. These stages overlap, they're not easily distinguished in individual patients. And to say that many patients will only develop the early infection stage. As I said, most people develop mild disease, upper respiratory tract infection symptoms, and don't go on to develop stage 2 and 3. What is also now known is that the initial phase is characterized by very high viral replication. So if you quantify the amount of virus, people's respiratory secretions, it's very high during the early phase, but rapidly declines within a few days. And the later stages of illness are far more characterized by pathology caused by the immune response to the virus, when the viral levels are actually quite a lot lower. So I won't go into any more detail about this slide, but it's there for your reference. So to speak about mild COVID-19, and for those people who've had COVID-19 and been labeled as mild, some of them have developed very severe symptoms, but it's mild because they're able to stay at home and they don't develop a pneumonia, but they can develop severe myalgias, severe fevers, but not sick enough to require hospitalization. The criteria in the national guidelines for mild COVID are essentially patients who have normal saturations on room air, they don't have tachycardia, a significant tachycardia or tachypnea, and they don't have a fever above 39 degrees with normal mental state. So that's the criteria that we use for defining mild disease, and the importance of doing that is those patients with mild disease do not need to be hospitalized. They can remain at home as long as they're able to self-isolate and not put other people at risk of infection. Obviously, if they're not able to self-isolate, we need to look for facilities in which they can isolate, and that will be discussed later on. Those patients who stay at home are advised to monitor their symptoms, and if they develop breathing difficulties, shortness of breath, they're advised to return to hospital because that might be a symptom that they're developing a viral pneumonia. So most of the rest of the talk, I want to discuss severe COVID-19, which is essentially patients who are sick enough to require hospital admission. And just to give you an overview and really emphasize from this slide the critical role that a person's age plays in the likelihood of developing severe COVID-19, as well as their risk of death from the disease. So this is data from a huge registry that's mainly based in the United Kingdom, but has contributions from another 34 countries, where they've put together data on now over 20,000 patients hospitalized with COVID-19. So I've really underlined hospitalized because this is not all patients with COVID-19. These are patients that are sick enough to require hospital admission. And what you'll see is that going up on the vertical axis is the age groups in 5-year categories. And then on the horizontal axis is the count of the number of people in that category divided into male and female. And you can see that admissions, among those 20,000 admissions, very few of the patients were under the age of 20. And even when one looks through the middle ages, from sort of 20 to 40, it's only a minority of admissions that are occurring among people in that age group. And the majority of admissions are people over the age of 60. And then if one looks in the blue, the mortality due to COVID, you can see it, you only start seeing a blue line at the ages, coming significantly at the ages in the mid-30s and above. And the vast majority of mortality due to this condition is people over the age of 50. So I think this is a very important message to keep in mind about who's at risk of developing severe COVID-19 and who's at risk of dying from this condition. Just to go on beyond the issue of age, obviously there have been deaths reported in people under the age of 60, but in younger people, the vast majority of those deaths are in people who have other comorbidities. And this is on the right-hand side, some data from general practice data across the UK, where they've looked at people's comorbidities and how that puts them at increased risk or an increased hazard ratio of death. I won't go into detail about that, but if one sort of distills out the message from this, is that the conditions that put people at risk of severe COVID and dying from COVID are diabetes, and I think Marianne will speak to that further about our local experience as a big driver of mortality from COVID-19, obesity, cardiovascular disease, pulmonary disease, so things like chronic obstructive pulmonary disease, liver disease, renal disease, having a malignancy, and having had an organ transplant and being on immunosuppressives for that. So that's emerging from multiple studies as some of the major risk factors for severe COVID. To move on to what the pathophysiology, or what are the mechanisms for severe COVID-19? Obviously, the hallmark of severe COVID-19 and what characterizes the vast majority of cases is that patients develop a viral pneumonia. So the viral replication spreads from the mucosal membranes of the upper respiratory tract down into the lower respiratory tract. It infects cells lining the alveoli. That causes inflammation and diffuse alveolar damage. The alveoli that obviously are important for gas exchange and oxygenation of the blood become filled with inflammatory cells and exudate, and that leads to hypoxemia or the failure to get sufficient oxygen into the blood. That's the hallmark is a progressive pneumonia with hypoxemia. Around the alveolar, obviously the capillaries and the arterioles that supply the lung, those get damaged as a secondary consequence of the alveolar damage. They become dysregulated and there's thrombosis within the microvasculature, and that is thought to contribute to the pathology. We now know that COVID-19 is a potent cause of systemic coagulopathy, so patients are at high risk for developing DVTs and developing pulmonary emboli. As a consequence of that, some studies up to 30% of patients with severe COVID have pulmonary emboli. And then patients go on to develop a hyperinflammatory syndrome, which is characterized by a systemic cytokine storm. So the proteins in the blood that drive inflammation, very high levels of those, causing a sepsis-like syndrome, resulting in multi-organ failure. And when patients are admitted to ICU, we know for any reason when they spend more than a week in ICU, they're at very high risk of secondary infections and they develop hospital-acquired infections. So those are some of the key factors driving severe COVID-19 and the mortality associated with it. So just to unpack some of those issues, I just thought it's useful to bring this to life in an image. This is from an electron microscopy picture of a type 2 pneumocyte. So this is one of the cells that lines the alveoli that has been infected in lab with SARS-CoV-2. So you can see the cell with the kind of villi-like projections, and then the small circular, black circular objects are the virus. On the right-hand picture, being shed, coming off the cell, replicating off the cell, and on the left-hand picture within the vesicles within the cell. And it's critical for you to understand it. The virus infects these cells, multiplies at huge amounts in these cells, and ultimately leads to death of these cells. And looking at the next picture here, the top left picture, is essentially depicting an alveolus and the virus replicating in the cells lining the alveolus. It kills those cells, so there's cell death of the alveolar lining cells, and that leads to infiltrate of inflammatory cells, the blue cells, lymphocytes, macrophages, neutrophils, and exudate, and those block up the alveoli and impair gas exchange. You can see that the capillaries are tightly clustered around the alveolus, and then there's secondary damage to the capillaries and the arterioles. We know that the virus is able to infect endothelial cells because they have ACE2 receptor, and that leads to the secondary damage, which then incites inflammation in the vessels, causing clots, as well as leading to dysregulation. And one of the factors is thought to be both the blocking up of the alveoli with the inflammation and the exudate, but also the dysfunction of the pulmonary vasculature, so that you don't get appropriate vasoconstriction to hypoxic areas, and you get a VQ mismatch, and that contributes to the hypoxia associated with COVID-19. What you can see on the right-hand side is that COVID-19 is able to affect multiple organs throughout the body. And I'm not going to go into detail about it. You can read through that on this slide that was prepared as a kind of layperson's guide to COVID-19. But just to say here that one of the reasons why COVID-19 affects multiple organs throughout the body is that it gains entry into cells via the ACE2 receptor on the surface of cells, and this receptor is widely distributed in organ systems around the body, and this slide just summarizes the effects that it has in multiple organ systems. And this is essentially, as I said, the hallmark of severe COVID-19 is a severe viral pneumonia complicated by adult respiratory distress syndrome, or ARDS. And you can see this is one of the patients that we've looked after at Groote Schuur with a severe bilateral ground glass infiltrate apparent on the chest X-ray and as well on the CT scan, so really extensive. We have obviously had many patients with milder COVID-19 where it's a far more patchy, discrete patchy infiltrate, but of the same ground glass infiltrate. And essentially the ground glass is representing fluid and inflammatory cells in the alveoli. This is some post-mortem images from a publication where they looked at a patient who had died from COVID-19, and in the top images you can see the lung, the surface of the lung with that, the white patches are essentially the areas where there's an inflammatory infiltrate. The cut surface of the lung, you can see the paler areas is where there's an inflammatory infiltrate. The bottom left-hand picture is an embolus within the pulmonary artery, and the bottom right-hand picture is a deep vein thrombosis. So as I said, a coagulopathy and large vessel thrombosis is prominent in patients with severe COVID-19. And these are just from another post-mortem study, some histology images on the left-hand side. The little black dots are lymphocytes infiltrating in the alveolus and the interstitium of the lung. And on the right-hand side, the eosinophilic tubular-like structures that are arrowed are microthrombi within the pulmonary vasculature. Again, an important contributor towards the pathology and the hypoxia associated with COVID-19. So to move on to some practical issues, how do we make the diagnosis of COVID-19? Essentially, this is what's being done at the testing centres across South Africa. It's a nasal swab. So a swab is inserted into the nasal cavity and is gently pushed back in a rotating motion about 10 centimeters or so. 10, 12 centimeters to the back of the nasopharynx, and is rotated around, and that's done in both nostrils, and then that swab is sent to the laboratory for a real-time polymerase chain reaction test. And the current turnaround time, at least in a hospital setting, is around 24 hours at best. We are gaining access to the expert machine, the expert platform you'll know from the TB testing, but there are now cartridges that allow us to test a PCR test for SARS-CoV-2. So some of the prominent laboratory abnormalities with severe COVID-19, lymphopenia, and that lymphopenia can occur early in the course of the disease and predicts patients who will develop severe disease, as well as predicts mortality. As a result of the coagulopathy, patients with severe disease can have raised D-dimers, representing fibrinolysis, raised CRP and ferritin, reflecting severe inflammation. Troponin T and BNP can be up, reflecting cardiac damage, and then laboratory evidence of renal and liver dysfunction. So to move on to management, the mainstay of management, probably the most important thing that we're doing for patients in hospital is oxygen therapy to address the hypoxemia associated with the condition, and obviously mechanical respiratory support in those patients who require that. Importantly, many of the patients have comorbidities, diabetes being the most important one, and that needs to be appropriately managed in the hospital setting. Patients' symptoms are treated. Often patients have severe back pain and myalgia and need analgesia for that. As I said to you, DVTs and pulmonary emboli are prominent, and so patients will receive anticoagulation. And if patients have severe COVID-19, we're not just giving them prophylactic anticoagulation, we're actually giving them full dose therapeutic doses of anticoagulation, because we know that so many of them will have DVTs and pulmonary emboli. I'll come back to this, but there's no proven antiviral therapy targeted at SARS-CoV-2 that's currently available in South Africa, although there are ongoing trials. And obviously in some patients where they are deteriorating and the decision is taken that they're not eligible for ICU support, then palliative care is instituted with the aim of keeping people as comfortable as possible in the last days of their life. So, as I said, the mainstay of support is oxygen therapy and respiratory support. And what I've just shown on this slide is the increasing levels of oxygen support that we're able to offer. And obviously this will depend on how severe the patient's pneumonia is when they come in and how that deteriorates during their hospital course. But in terms of the initial support is with nasal prong oxygen, moving over to a 40% face mask, then a face mask with a rebreather bag that allows us to deliver 60% oxygen, and then moving on to high flow nasal oxygen, and I'll show you that on the next slide, that can deliver up to 100% FiO2. And some patients who deteriorate despite all of that, or come in extremis, require intubation and mechanical ventilation, which of course allows you to deliver both 100% FiO2, but also provide positive pressure to assist their spontaneous breathing. So one of the major advances in the service that we've been able to offer as we've expanded our COVID-19 services at Groote Schuur and at other hospitals across South Africa is high flow nasal oxygen. So this allows us to draw up to 60 liters a minute of oxygen from the oxygen supply in the wall in the hospital, and it then goes through the high flow oxygen machine on the left, that's shown on the left hand side, which humidifies the oxygen, brings it up to body temperature so it's comfortable to breathe in, and then it's delivered through the nasal prongs that are shown in the right hand picture, and delivered at a flow rate of up to 60 liters per minute. So that's 60 liters of oxygen going into somebody's airway. It essentially replaces all the CO2 in the upper airways with very high concentrations of oxygen, which are then delivered to the alveolus with some positive pressure. And this has allowed us to keep a number of patients who would have otherwise required mechanical ventilation, and we know that putting a patient on a ventilator has its own negative consequences, to have this oxygen support and have that for several days and then be weaned and not require mechanical ventilation. So we've had 6 of these units at Groote Schuur. We've just got another 14, and we'll be able to supply this to more patients who are in severe respiratory failure and potentially keep them off mechanical ventilation. One of the other innovations is proning, and this involves somebody turning over and lying on their stomach, a very simple intervention, but it's shown that doing this in about a quarter of patients can lead to a very substantial increase in their oxygen saturation in the blood. And this is something that was previously only done in patients on ventilators, but we're now doing it in people in the general wards, and therefore it's called a wake proning. And it allows the posterior parts of the lung to recruit more alveoli and to reverse the atelectasis, and the anterior parts of the lung that are often better ventilated because of the effect of gravity. It allows the blood supply to improve to those areas. So overall, it allows for a better matching between ventilation and perfusion and better oxygenation of the blood. And I've seen patients where literally rolling them onto the stomach allows their saturation to come up by 10%. So they might be going at a SATS of 80%, and rolling them onto their stomach, it goes up to 90%. But as I said, that's not in everybody. It's in around a quarter of patients. In terms of antiviral treatment, I'm not going to say much about this other than to say that there's only one treatment that has been shown in a clinical trial to improve outcomes, and the effect was modest. So this is remdesivir, and this was a trial that was published last week. And what the benefit was a faster time to recovery. So time to hospital discharge was 11 days in those who received remdesivir compared to 15 days in those who received placebo. There was a slight reduction in mortality, but this was not statistically significant, but more results are expected, but a modest benefit. It's not available in South Africa. It's an intravenous infusion. It's still experimental. There are a number of other studies ongoing into drugs like chloroquine, the anti-malarial drug, but those are all being done in the context of clinical trials in our setting. So to finally, just to end off with, to say something about the clinical service at Groote Schuur Hospital. So we admitted our first patient with COVID-19 in around mid-March. And at the beginning, we just had one ward, we had a testing center, and obviously with the increasing numbers of patients coming to the service, we've had to scale up, and we're scaling up a lot faster now with wards opening, new wards opening frequently. We've had 240 patients with COVID-19 admitted to Groote Schuur, many of them obviously still admitted. But the layout is generally that, just in general terms, is that we have a testing center in the P4 parking deck where patients come for outpatient testings. Most patients will go home to await the results of their test. If they're sick enough to require hospital admission, they're admitted to one of the person under investigation or PUI wards. And there are 3 wards currently at Groote Schuur being used to admit patients that are classified as PUI, mainly with respiratory and cardiac conditions. If those patients end up having a positive test for COVID-19, they move to the COVID-19 wards. If their test is negative, they obviously go to the general medical ward. And there are currently 5 COVID-19 wards open at Groote Schuur. Obviously, those wards are accepting referrals from the emergency unit as well as other hospitals. And those patients in South Africa, only those patients that require mechanical ventilation are those that go to ICU. So the high flow nasal oxygen is being done in the wards. Only those patients who are on a ventilator go to the ICU. Just to show you 3 case vignettes of patients that we managed, just kind of to bring the service to life in terms of its clinical aspects. This was a woman who had an unfortunate outcome. She died from COVID-19. She was HIV negative, had previous TB, was obese with newly diagnosed diabetes, was admitted about 3 weeks ago, had a good baseline, was admitted with 3 days of symptoms. By day 7, she had increasing oxygen requirements, was receiving the high flow nasal oxygen and proning. We started her on therapeutic doses of Clexane or enoxaparin, but she deteriorated further by day 11, requiring very high concentrations of high flow nasal oxygen, but was maintaining a SATS at around 90% with proning and the high flow nasal oxygen. But we were concerned as to why she remained so hypoxic. And at day 18, she went for a CT scan and it's shown on the left-hand side you see the extensive bilateral ground glass infiltrates. On the right-hand side was the scan that she went for, and what you see, what I've arrowed, the top arrow is showing the normal blood in white in the pulmonary arteries, and in the bottom arrow, that tubular grey structure is a pulmonary embolus obstructing the right pulmonary artery, so a massive pulmonary embolus. And soon after she came back from the CT scan, she had an arrest and died. So she had severe COVID-19 complicated by a pulmonary embolus that led to her death. This is a patient with a good outcome despite a very intensive and complicated course in the hospital. 38-year-old man, HIV positive, a new diagnosis with a high CD4 count. He was obese but previously well, admitted with 5 days of symptoms. On admission to Groote, he was an extremis in respiratory failure, was intubated immediately and was mechanically ventilated in ICU for 14 days, complicated by acute kidney failure, but was eventually extubated, mobilized in the ward, and was actually discharged yesterday home. And finally, just to show you one of our success stories on the high flow nasal oxygen, 47-year-old woman, HIV positive on antiretroviral therapy, a high CD4 count and doing well, newly diagnosed diabetes, was also obese, admitted with 4 days of symptoms. You can see she had profound hypoxia on admission with saturations of 62%. If this was any other form of pneumonia, she would have been intubated immediately. But we know that some of these patients can do well without intubation and ventilation. She was placed on a high flow nasal oxygen with an FiO2 of 94%, high flow rate, and her tachypnea improved. Her saturations improved to around 90%. She again received therapeutic Lexane, was on high flow nasal oxygen for 7 days and has been gradually weaned, and was just on nasal prong oxygen when I saw her in the ward yesterday. And you can see that it's a poor chest X-ray, but you can see extensive bilateral infiltrates. So despite the very severe pneumonia, she was able to escape having to be ventilated, and I think that improved her prognosis. One question that we always get asked is the question of what is the effect of HIV on COVID-19, and it has major implications for our management of patients, because when patients come in with respiratory infiltrates, it could be COVID-19, but we have to consider differential diagnosis like pneumocystis pneumonia as well as TB. We've had patients who've come in with HIV positive with both active TB and COVID, and obviously the TB needs to be treated. Important to point out that because COVID causes a lymphopenia, that even those patients who are doing well on antiretroviral therapy with a high CD4 count, there can be a temporary drop in CD4 count due to the COVID-19 alone. It doesn't mean that their antiretroviral therapy is failing, and one presumes that that will improve in the weeks following the acute COVID. It's currently unknown if HIV itself is a risk factor for severe disease and death, but I would say that we are not seeing, we had anticipated we might see a lot of patients with advanced HIV in our wards with COVID-19, but that's not something we're seeing yet, but we will have to await further experience to be able to decide for certain whether HIV is a risk factor for more severe disease and death. In patients who are admitted with HIV and COVID-19, obviously we need to make sure that they're on appropriate antiretroviral therapy. If they're not on ART, then we generally start 1 to 2 weeks into their admission, but that's not based on any prospective evidence. In terms of de-isolation, so saying that patients can interact with family members and are no longer infectious, the national guidelines say that provide this guidance. If patients are asymptomatic and have a positive COVID test, they should remain isolated for 14 days and can de-isolate for 14 days after the positive test. If they have mild disease, they haven't required a hospitalization, it's 14 days after symptom onset, and severe disease, it's 14 days after clinical stability achieved, which we take to mean once they come off oxygen support. So just one or two final comments, and to you generally as final year students coming back into our health services and confronting the reality of COVID-19. Just wanted to say that, you know, all of us have to come to terms with the reality that our health services and our society will be dealing with COVID-19 as part of everything that we do until a vaccine is discovered and until it's available everywhere across the world. And so that is potentially in the next 12 months, but it could be longer. And we have to find ways to deal with COVID-19 and work around it, and obviously provide the best care that we can for patients with COVID-19, but also with patients with other conditions. What I've really tried to emphasize in this talk is that severe disease, severe COVID-19 and death occurs mostly in older people and those with comorbidities, and that's certainly what's been reported in literature and our experience. And then to say to you that with proper use of PPE and very careful attention to infection control practices, we can't make the risk of being infected zero, but we can substantially reduce the risk to ourselves and to others. And we've got to practice that both in the setting of the wards, but also in every setting where we are, be it a residence, be it where we're sharing lunch with colleagues. Just always pay attention to all of the aspects of prevention of COVID-19, including social distancing, wearing masks, hand hygiene, and frequent disinfection of services. And just to end off, these are colleagues working in the COVID-19 ward, and pay tribute to the medical staff, the nurses that are working in the ward, the support staff and the management that have allowed us to scale up the services to deal with this challenge facing us. So thanks very much for your attention, and I'll stay on to answer questions at the end.
Thank you very much, Professor Meintjes, for a fantastic presentation that really gave us a comprehensive summary of the clinical issues in this new disease. There are quite a few clinical questions in the students' Q&A chat already. In the interest of time, I think we'll move on to the next presentation, but we will answer these questions in the discussion, and if not time for addressing them in the discussion, we'll also respond to them directly in the Q&A chat. So without further ado, let me introduce you to our second speaker, Associate Professor Mary-Ann Davies, who works at the Health Impact Assessment Unit at the Western Cape Provincial Department of Health, specifically in the Epidemiology and Surveillance Subdirectorate. So we move on to Mary-Ann from the clinical considerations to looking at the province and the numbers around COVID. I'll hand over to you, Mary-Ann.
Okay, hi everyone. I'm just going to try and share my screen, and hopefully that works. Can you see that?
Yes, we can, Mary-Ann. You can put it on slideshow.
Okay, perfect. So thanks very much. I thought by way of introduction, I'll age myself and tell you that I graduated in 1995. And I think of our class of graduates and the people that graduated at that time as the HIV generation, because we graduated at a time when we suddenly saw HIV emerging as a really important clinical disease in our country, and we lived through several years of HIV without antiretroviral therapy, and I think that has shaped many of our careers. And so when I thought about this class, I thought you guys are the COVID generation. And that may seem somewhat daunting, but it's also very exciting and gives you an opportunity to be clinicians at a time when we are learning about a new disease, which is exciting. So I work in epidemiology and surveillance, and a big part of my job is to produce and understand the numbers that you see. And I'm sure this was shown in quite a few of the presentations on Friday, and it gets updated at 1 o'clock every day. It's our public facing dashboard. I had to prepare these slides before 1 o'clock today, so these numbers are already out of date. And we currently have had a cumulative 15,756 cases of COVID in the Western Cape, just under 800 in the last 24 hours, and the fatalities have climbed to 357 since yesterday when I took this screenshot of the dashboard. I highlight the dashboard is interactive. You can look just at the metro. You can adjust the dates if you want to see what's happened recently. And I hope you've all spent some time looking at it and playing around with it. And I also want to highlight a couple of things about the numbers, and note, for example, here that you see the number of cases by sub-district. and that it looks like Tygerberg is the place with the most cases, and I'll come back to that later in the presentation. So, to take you back to some of the things that you've learned about a long time ago in your medical careers, really what we're doing is epidemiology and surveillance, and the same principles that apply for any disease are now being applied for COVID. And to remind you of that definition, it is the ongoing systematic collection, analysis, and interpretation of data and the timely dissemination of the information for action. And obviously in the time of an outbreak, that timely dissemination is critical because every day things change really quickly, and I'm going to emphasize that in the talk. So what are the key things that we count and that are shown in the dashboard? And I'm going to talk to all of them and a little bit of what is helpful to understand in order to interpret those numbers. So we talk about tests, we talk about number of cases, we talk about admissions or ICU admissions, which Graham has already referred to. We talk about deaths, and we have recoveries. And so let's start off by looking at tests and number of cases. So you'll see that we report about 125,000 tests have been done. And importantly, there's a very close relationship between tests and cases, because at the moment, our case definition requires that you have a positive test, and so you can only count someone if you've tested them, and that means you will only count what you have looked for and found. And so importantly, when we think about the number of cases we are seeing, what determines that is how many tests we're doing, who's getting tested, and how long does it take to get a result. And just to show that in a schematic at the bottom, what we're actually counting is the small white circle of diagnosed cases, but that is just a fraction of all the cases that are out there in the population. And as Graham has alluded to, that includes people both with symptoms and without symptoms. And we think that in the Western Cape, we are probably only diagnosing 10 to 20% of cases. So that number of nearly 16,000 now is probably only about 10 or 20% of the total number of people who've actually been infected in the Western Cape to date. How many tests are being done? And what we often look at is that total number of tests and the 125,000. But what's important is not just how many are being done, but of course, because I'm a public health person, what I care about are the denominators. So how many are done per person? So you'll see on this figure, which is a little bit out of date, that the Western Cape hasn't done the most tests, but they have done by far the most tests per 100,000 people. And that is one of the reasons why the Western Cape has a runaway epidemic, because we're finding more people. There are other reasons, and it is very likely that the epidemic started earlier here undetected, probably because of more tourists. And we may have slightly faster transmission than in the other provinces, and I can talk to that more if there's time in the questions. But even if we look within the Cape Town Metro, and you'll remember I highlighted in the earlier slide that Tygerberg, which is shown in the dark red block in the map on the left, had the most cases. There is huge variation in the number of tests per 100,000, and one of the reasons that, which are shown in the blue bars on the right-hand graph, one of the reasons that Tygerberg has the most cases is partly because they have the biggest population, but they've also done the most tests per 100,000 people, and you can see that there's quite a lot of variation across the different sub-districts in the metro in terms of the number of tests per 100,000. We have tried to target our tests to where we think the most cases are likely to be and where we are more likely to find cases. And so it's appropriate that some areas have had far fewer tests done than others, but it does really impact if you're just looking at number of cases. That may not represent the true population burden. What you can also see is once we take into account the number of people living in different areas, that Tygerberg actually doesn't have the most cases per 100,000 people, but in fact Khayelitsha and Klipfontein are our two sub-districts with the most cases per 100,000. But again, that's a combination of how many tests have been done in that area, and also, coming to my next slide, who actually gets tested. So you'll remember that fraction of diagnosed cases amongst all cases, and there are a number of things that influence who gets into that white circle of diagnosed cases. And one of the best ways to illustrate this is the fact that our case definition of who could get tested changed. So in March, when we were seeing our first cases, you could only get tested if you had symptoms of disease and you also had a history of definitely being in close contact with someone with COVID, or you had a travel history. After the 3rd of April, we realized that we had transmission not only from imported cases and that it was important to actually test everybody who had symptoms. And if you look at the graph on the bottom right, which only takes us into April, you may actually remember that we had this week in early April and late March where it seemed that the number of cases were dropping, or certainly we weren't seeing massive increase in new cases. And it happened to coincide with when lockdown started, and there's this lovely sort of kink in our curve of numbers. Now, there are a number of reasons for that kink, and probably, yes, lockdown and some of the pre-lockdown measures did contribute. But one of the things that I'm fairly convinced contributed was that for a while, our case definition only allowed us to test people who had a known close contact or a travel history. And so we probably missed some of our early community transmission in people who didn't necessarily know that they'd been in contact with someone with COVID. And in fact, some of our sort of early sentinel cases in hospital were people who didn't know that they'd had a close contact. And you can see Slim Karim, who I'm sure you've all listened to or seen on TV, who also argued that that initial testing approach may have been too limited. Now, what are the things that are influencing who gets tested? Well, I'm sure you've read seen in the media some of these workplace clusters, the ShopRite, pharmaceutical manufacturing factories, police stations, that what we've seen is a number of clusters in workplaces. And some of the spread in the Western Cape has been ascribed to spread in the workplaces, and I think that's probably true. But one of the things is that the incentive to get tested is much, much greater for essential workers, because if you arrive at work with a cough or a sore throat, you will immediately be told you can't come to work unless you can prove that you are COVID negative. And so a huge factor driving our testing in relatively well people at the moment is people who have mild symptoms, present at work, but cannot work unless they can show that they are COVID negative. And so quite a bit of our testing, at least until recently, was actually being done more to exclude the diagnosis. And you can see that if we look at our number of cases by age and sex, that we've got a bulge in our cases in the sort of 20 to 50-year-old age group. So people who are working, and particularly more women, because of it being driven by essential workers, especially in the retail sector. In addition, what has sometimes driven up or where we've detected a lot of cases is that once you find that cluster of cases in a workplace, some of those workplaces have felt that it would be important to actually test everybody in the workplace, irrespective of symptoms. And where that's been done, we found that up to 50% of people in the workplace are positive, and that about 30 to 50% of those have no symptoms at the time of test. And some of them do go on to develop symptoms, but as Graham has indicated, it seems about 18 or 20% actually never develop any symptoms at all. Now, normally people without symptoms would not be tested under our normal testing guidelines, but there certainly is this fairly large asymptomatic or pre-symptomatic burden of people with COVID who we are not seeing in our numbers. And then finally, how long does it take to get a test? What you're looking at in the graph is the time from specimen collection to result for the different provinces in South Africa by calendar week. And you can see that this has increased as our number of tests have increased, and Cape Town is the light blue line. So we have the second longest overall turnaround time. And so when you're looking at the cases that we say were diagnosed in the last 24 hours, what we're actually looking at is history. We're looking at people who had symptoms up to a week ago. And the diagnoses that are coming through with the shorter turnaround time, the 24-hour turnaround time, are those that have been prioritized. And so when you look at the positivity rate just in the last couple of days, it can be very difficult to interpret, because you're looking at a mix of specimens that have been prioritized because they're urgent, as well as people who were diagnosed or who were tested a week or even more ago. And in the headlines in News 24 this morning was highlighting that we have about an 18,000 test backlog in our laboratories. And recently, 2 members of the Ministerial Advisory Committee wrote an editorial in the South African Medical Journal about the challenge of the testing strategy and the fact that we're not able to get results fast enough, both to count our numbers accurately, but also to manage patients in hospitals and to be able to contain and contact trace around people at a time where it would actually make a difference. So next I'm going to talk about admissions and ICU admissions. And what you're looking at in the graph on the left-hand side, the blue line shows the the daily number of patients being admitted across both public and private sector. The orange line shows patients admitted to ICU, and the red line shows the proportion of all hospital patients that are admitted to ICU. Just to put that in context, in the donut on the top right, as Graham mentioned, and as is in keeping with the spectrum of disease that we've seen internationally, the majority of patients do well and don't need to get admitted to hospital, so close to 90%. And in our setting, we're seeing about 13% of people being admitted to ICU. But what I want to highlight when interpreting these numbers is that is 2 things. The first is to show the rapid increase that we're seeing in the number of admissions, which matches the rapid increase in the number of cases. And when I was preparing these slides, I thought, oh, I'll just use the slide from last week because it won't be that different. If I'd used the slide from last week, it would have stopped where the black arrow is, where we had about 55 admissions per week. And you can see that when I update that, we're actually sitting now at close to 100 admissions per week. And that really, our doubling time in the Western Cape is probably around 8 days. So that means in the next week, we're going to be sitting at, sorry, not per week, per day. We're going to be sitting at about 200 admissions per day. And that is still a fraction of what we will expect to see as this epidemic unfolds in our setting. And I think we're expecting to see at least 3,000 admissions in our worst week, and it may even get worse than that. So just to be aware that although things feel like we're getting a lot of admissions, at the moment we're still actually fairly early on. The second thing I want to highlight is the proportion of patients admitted to ICU, which is the red line, and you can see that that was quite high early on and has dropped. And so when you're looking at that figure of proportion admitted to ICU or the number of patients admitted to ICU, one needs to be very aware that there is some clinician discretion and also learning that goes into whether someone is admitted to ICU or not. And so an ICU admission in Spain may not be the same as an ICU admission in South Africa. And we can already see in our own setting that an ICU admission in the private sector, and sorry, the bottom should there say public sector, no, it's correct, is not necessarily the same as one in the public sector, which speaks to inequity and the need for us to address that as we plan going forward. So 45% of all ICU admissions are in the private sector, but only 28% of all admissions are in the private sector, showing that disproportionately ICU is happening in the private sector, and part of the decline in the percent of patients being admitted that we see being admitted to ICU is as this epidemic has shifted from the imported epidemic, largely in the private sector, to more public sector patients. It's also partly as clinicians have seen very poor outcomes in ventilated patients admitted to ICU, and the innovation of using the high-flow oxygen, which may not need to be delivered in an ICU setting. And Graham may be able to speak more to that at the end. Moving to the right, and the total admissions that we've seen, and the number of deaths, which is obviously the other outcome that we are reporting, and I've now replaced added a black line to the slide, which is the number of deaths. And again, you can see here that if I'd used the data from about a week ago, we were sitting at about 10 deaths per day, and that has rapidly increased, and we've had about 25 to 30 deaths per day in the last few days. And again, that is what we expect with an exponentially increasing epidemic. But let's just scrutinize that number of deaths a little bit more, and you'll see here that the number of deaths on this slide is lower than the number of deaths here. And I wonder if you can think to yourselves for a second why, when I look at the deaths in our hospital admissions data, we're seeing something different when I look at the total deaths. And while I was saying that, you probably figured out that that's because a proportion of people don't die in hospital. And those are particularly challenging for us to count because we might not know about them. And also because they may not yet have had COVID diagnosed. Some of them have had COVID diagnosed and have elected not to be admitted or don't make it to hospital once their illness becomes severe. But increasingly, when we're talking about 318 deaths, that's not too difficult to count. But as those numbers increase, it will be very difficult to have an accurate sense of our total COVID-related mortality, both in and out of hospital. But one group that is looking at all deaths is the Medical Research Council. And what they're looking at is what we would expect in terms of deaths from all natural causes, which is shown in the orange lines, and the black line shows what we have seen so far in terms of deaths from all natural causes. And you can see this was last week's report that we're starting to see an increase, but it is following what we would expect, and in fact, if anything, probably slightly lower, and that may be because social distancing has resulted in fewer infections from other conditions such as flu and TB. But they will be watching this very closely, and they release a weekly report, and in fact are going to be releasing one this afternoon, which will be very interesting to start to see if we are starting to see a difference in our overall death pattern. This I'll go fairly quickly through because I think Graham highlighted this in his talk. When we compare deaths between different communities, it's important to think about the underlying age structure. Here we're looking at the proportion of people in each age group on the left-hand side among all cases, moving to the right among hospitalized cases, then ICU cases and those who have deceased. And essentially you can see that the proportion of older patients who we know have a higher risk of mortality increases as we move to the right. And the mortality that we've seen in our setting is substantially higher in those over the age of 60 years compared to younger patients, and really almost negligible in the younger patients. We have had 2 deaths in the under 20-year age group. One was in a neonate who was born at 31 weeks and so extremely premature and not really even sure if we should call it a COVID death. And the other was in an older child, but who had severe dilated cardiomyopathy. So we certainly haven't seen deaths in previously healthy children. Here is just a look at the issue of comorbidities, and what we're looking at here is the proportion of patients with comorbidities on the left-hand side for those who are over 55 and the right-hand side for those who are under 55. And the choice of 55 is somewhat arbitrary, but it gets me to put myself into the younger age group, which makes me feel good. And we're looking, as we move from left to right in these graphs, on the left-hand side, people who haven't been diagnosed with COVID, and as we move to the right, more severe disease. So COVID admissions, and then finally COVID death. A couple of things to point out. The first is that clearly the older people generally have more comorbidities, and if you've done the sums, you'll see they add up to more than 100%, and that's because several people have multiple comorbidities, as you can see in the donut on the top right. The second is that there's clearly an increase in the proportion with comorbidities as we move from less severe to more severe disease. So those who are admitted and those who die have a far higher proportion of them have comorbidities. And then the third thing to point out is that this is based on data that we already have on patients who routinely attend our public sector services, so who have previously been diagnosed with one of these conditions. But a condition that we don't have good data on in terms of diagnosis is obesity, which is emerging as a key risk factor for COVID morbidity. And we do have that information collected on the deaths, and you can see that it does seem to be an important feature, but it likely is extremely under-ascertained. And I think in all three of the patients that Graham presented, there was an issue of raised BMI. So even though we do have this information, I think because it isn't a diagnosis as such, it tends to be underreported. In the younger patients, you can see we do have what appears to be a slightly increasing proportion with HIV and TB, particularly among those who are admitted or have died, and that's a space we're watching very closely. But importantly, many of those patients also have other comorbidities like diabetes and hypertension. Finally, the recoveries. I always tell people to ignore the data on the recoveries, and you'll note that it's got an asterisk there. When one is following 15,000 people, being able to know how many of them have actually recovered is almost impossible unless you are phoning all of them on day 14 and saying, are you feeling better? And so when we had small numbers of patients, that's what we did. But at the moment, unless you are in hospital or have passed away by day 14, you are considered to be recovered once you are 14 days post-diagnosis. And I think whichever is your favorite dashboard that you look at around the world, whether it's Johns Hopkins or Worldometer or whatever one you choose, I always look at those recoveries with a bit of a grain of salt. Finally, although you're the COVID generation and we all feel consumed by COVID monomania at the moment, this was an article that appeared in the Daily Maverick yesterday, which is to remember that people have other conditions and that we mustn't only be thinking about COVID. And what we're looking at here is what's happening with routine HIV and TB services. And on the left-hand side, we're looking at ART initiations. Month on month over calendar years from 2018 to 2020. And you can see that every year there has been a reduction year on year in ART initiations, but that's what we expect because so many of our population have already been started on ART. But you can see a much bigger drop in April 2020 compared to 2019. And then if we look at treatment initiations for TB, we see the same pattern. And so there is a real concern that even if we get through COVID, what we may see in months to come are the effects of reduced service provision for our routine health services. Another impact that we've seen, and I'm going to end with this, is we looked at the deaths from natural causes. If we look at the deaths from unnatural causes, is the striking drop in the deaths from unnatural causes during the lockdown, far fewer homicides, obviously far fewer road traffic injuries. And this has actually been important because it's helped to keep our hospitals empty or more empty of trauma patients than we would otherwise see. But it's also something that we need to watch very closely as we move to level 3. And I think I'll end there. Thanks.
Thank you very much, Marianne. That was an excellent overview of the complexities from a surveillance and public health perspective. In the interest of time, I think we'll move to the next speaker and then take questions later in the discussion period. So I'd like to hand over to our third presenter for the afternoon, and that is Dr. Virginia Zwigenthal, also from the Health Impact Assessment Unit at the Western Cape Provincial Department of Health in the Health Research Subdirectorate. So over to you, Virginia.
Thanks very much, Nisha, and thanks very much for inviting me. I'm going to be talking about more general issues around the health system response. I have been mostly involved in the case and contact tracing strategy, and I will refer to that as we go along. But I think from what you've heard already from both Marianne and Graham is that we're in a situation of quite rapid change with increase. Now we're on an upward slope of increasing numbers, increasing deaths, and we need to think about how we and the health system is able to respond to that. So that's part of what I'm going to be talking about in the course of these slides. I'm going to try and share. And can you see anything?
Yes, we can see. You can just put it on slideshow mode.
Fantastic.
Thanks.
Okay, so I've kind of builded as as changing and disrupting the way we work, because it really has changed everything that we do, particularly in health impact assessment. You know, the creation of those graphs, we've had to create those graphs from scratch and get them to go live and get them to be available for the public to see. The way we've restructured the hospital, all of that is because we've needed to, and we've been able to respond to the situation that we are faced. So, you know, COVID-19 has been a huge disruptor, and we know that in our own personal lives. There's no such thing as business as usual in the health services. And this is partly we are feeling our way as we go along. There's no global matrix or blueprint of how to handle the epidemic. We watched with bated breath what was happening in Italy when everybody was being admitted and dying. And so we knew that we had to get our act together. So it's really changed the way the world works, how South Africa works, how Cape Town works, and how we know it. It's changed the way we engage with our family if they're staying with us, Zoom meetings, WhatsApps, how we engage with friends if we can't see them, how we've engaged with learning, how you busy learning now, how we start to work. We're working from home now, and all the networks that we have created have changed considerably. You know, the people that I'm working with now, I haven't known for more than, you know, a couple of weeks at most. There are people that I'm working with who I've never met in person. So the networks that we're working with and engaging with and sharing our lives with are completely different to what we ever knew. It's changed the way people's livelihoods are created. No restaurants, no flights, no hospitality industry. That is all gone. It's had huge implications in communities with food, security, how people engage with each other, and of course this is in the health system as well. But I just want to pose, do you think this is only a bad thing, or are there some fantastic things that have come out of it as well? So the health department's response to the epidemic, it has depended on where we are in terms of disease transmission. On the right hand side you will see that there's a phase in blue called the epidemic preparedness, where we have no cases, and that was where we were in February, where we created the protocols for screening and triaging within health facilities. We were preparing the system for a surge, trying to find places that we could set up as isolation facilities, quarantine facilities, field hospital facilities. We're doing all that kind of field work, that footwork rather. We had to devise risk communication strategies, and then as soon as we got our first cases, we started active case finding. So that's the epidemic preparedness stage, which was largely February, beginning of March. Then once we started getting sporadic cases, we were very, very on it to test and trace each case, contact all their contacts, make sure that they knew exactly what they needed to do, stay at home, isolate yourself for 14 days, and so on. So that's what we did really in the stop transmission phase. We isolated all the positive cases, quarantined all the contacts, and that's at that stage we had the imported epidemic in the Western Cape. We didn't really have people who had real big problems with isolation and therefore needed to go to an isolation facility. That came later. We also started to restructure our health facilities to screen people as they came in, and people who were ill, they were shifted to another queue in order to get tested. And we had to set up all those kinds of facilities. So that was where we had sporadic cases. Then our next phase was to contain and mitigate. This is the yellow, where we discovered there were clusters of cases. We found that we had clusters of cases in essential workers, in factories that were pharmaceutical factories, and in the supermarket chains. That's where we found them, and I think we were the first in South Africa to find that. Literature from in the international literature has recently published that clusters of cases in work settings were a big driver early in their epidemics as well. So we continued to test and trace household contacts and isolate and quarantine them as well. We started at this phase, which was in end of March, April, and now into May, where we found people with food security issues, with inabilities to isolate, and we had to make a plan through disaster management, who had to reframe their own work in order to fetch people from their homes where they felt they could not isolate, take them to an isolation facility, and then stay there until their 14 days was up. It wasn't they did go to hotels, and they still do go to hotels, but it's not a hotel like being on having a holiday. It's hard, it's difficult. You have to be isolated in your room by yourself, and you get kind of airline food. So that's what we also had to set up. And now we're in the phase of protecting the vulnerable and the workforce, which we can talk about a little bit later. Now we've got a sustained community transmission. So these are the 4 phases that the WHO put out as far as where countries can expect to be going. So the continuum of care that we have are following is on your right-hand side, there's community prevention with a whole of society approach. Going out there, going to communities, telling them what the effective ways of preventing themselves from getting infected and from passing on infection, social distancing, and this is very difficult in many of the communities that we have got where the epidemic has become very highly prevalent. Screening, which is it's not like doing a screening test, it was asking a whole series of questions, and if people screen positive or say they have symptoms, then doing the test. Then on to isolation of cases for the cases, and then contact tracing, finding out from them who their contacts were, and then quarantining their contacts, either at home or also in a quarantine facility. So cases then either, and 85% of the cases that we find are actually very mild, as Marianne said, and can stay at home, and if they can self-isolate at home, don't need to be seen anywhere else, but some do require hospital admission and so on, and palliative care. We've talked about that quite a lot. Once they're recovered, they can go back to work soon. There's also a whole function about when you have deaths. There's a whole lot of regulations about deaths and burials and funerals, how the body's got to be prepared, how you can't have a funeral with more than 50 people, how people are not allowed to come to the house of the person, and it's really impacted on communities in a great deal. In fact, part of the epidemic moving from the Western Cape to the Eastern Cape, we believe, is people taking bodies back to the Eastern Cape for funerals and burials, and I think that's one big way that we've actually spread from the Western Cape to the Eastern Cape. All right, so in primary care, promotion and prevention, that's what we're doing. We deal with the mildly ill. We've changed the patient flows, as I discussed, and in inpatient care, we've talked about that already. I think we're going to be soon confronting, if we don't increase our capacity, discussions and really difficult situations where do we have to ration care and ration access to ICUs. We'll talk about the quarantine facilities just now as well. So I'm just going to talk about our own experience. The initial health system change, our focus really was on the contact tracing. So this is what it was. There's this guy making a phone call in front of his computer. That's how we worked. It's all telephone work. So we did a huge amount of contact and case and contact calling while we prepared for the expected morbidity and mortality. There was a lot of work put into educating clinicians and planning for repurposing of clinicians. In primary care settings, medication was dispensed for up to 3 months instead of once every month. So to decrease the amount of flow to going to primary care facilities. Hospitals also changed. They closed their elective surgery slates and many of their OPDs so that we could both protect the health system and well patients not to be from becoming infected. It required a huge amount of innovation and building onto information systems to inform the epidemic. So these are the kinds of graphs on our right with the hotspots, and that's the Tygerberg hotspots that you can have a look on the web that we were able to produce. And we created some of these from scratch, building on what we already had, but adapting, innovating, adding, and so on. It required a whole new way of working. You started working with people you hadn't worked with before, across the silos that we're quite familiar with in the health system and then across the hierarchies that we have. So people working laterally with people and not getting huge amounts of permission necessarily for doing what you needed to do. You didn't have to check things out with your supervisors. You just knew what the need was and you did it and reported back and tweaked how you went. We also in primary care have spent a lot of time on building community-oriented primary care approaches. So that is also building on what we had before. So community health workers who have a relationship with facilities and with the substructure officers in the Department of Health, doing door-to-door work, as you see, informing and educating communities about how to prevent and promote prevent infection. First of all, they were the forerunners for the screening and testing strategy, where we found that we had a few a little outbreak, a little cluster in a particular area. That's where we did screening and testing. So the community health workers would go door to door with loud hailers sometimes to inform people that we're going to be doing screening and testing in the next few days, so that they can come for screening and testing. So that's how we worked with community-oriented primary care. And now we're no longer doing this, and we can discuss that in the questions if people wish. We're now more or less confining our screening and testing to health facilities because we're quite overwhelmed with the amount of tests that we've got, and we should be thinking much more carefully about who we test. So now they do home visits to people in need for food parcels, for those who are ill, to assess the situation and to assess the situation whether people can isolate. So that is what community health workers are now doing. Early in the epidemic, we had a lot of weddings that when we had the imported epidemic. People came from overseas to attend weddings. We had at least 4, and then infected a whole lot of wedding guests. And in fact, the first death that we had in the Western Cape was one of those cases that arose from one of the weddings, and who did indeed die from a pulmonary embolus. So we started out with weddings, and then we moved to workplaces, and that's the second phase of the epidemic. So it's more or less coincided with the first big shutdown, and we started identifying the clusters in workplaces, in supermarkets, and then they had a ballooning epidemic started. So we, as public health people, started first managing workplaces. Mary Ann was one of the occupational health type of, had to switch gear and learn how to engage with managers, give them instruction or support them for what they needed to do, to clean places, identify the close contacts, send people away, get people tested, and so on. So that was one of the things, the identification of the clusters, and then the big effort on case and contact tracing. Now this was through the whole concept of a pod, and over here on the right hand side you'll see that this is what a pod is in the business world. They are people who have a high degree of autonomy, but they are all focused and working on the same thing, and that is what we created with the pods. Everybody worked alone, but we all worked with WhatsApp groups, and everybody selected or had a case, and they followed them up. So they weren't instructed exactly what they needed to do, but yeah, I worked quite a lot with the recruiting volunteers, and we made appeals through the CANs, which you are possibly familiar with, which is the neighborhood groups, and UCT, where we made an appeal about 6 weeks ago. Initially, we had 120 volunteers, and that has grown slowly over time to 212 that we have now in our database. We first recruited, then we documented them, got them to sign a confidentiality clause. We sorted out training for them, we allocated them to pods, and then we got the pods to operationalize. And that was a very quick turnaround time. Sometimes from recruitment to operationalizing was a matter of 2 days. We first worked individually, and then we developed new pods as new people joined up, and now we were up to 9 pods at one time. We also developed this and added on to a program that gives that has been developed in the province called the Single Patient Viewer, which is where everybody who is seen in the public sector has their has an identity and a description of all the various engagements they've had, and all the diagnoses as well. So we created a new instant of for COVID, and the way we did this work with the pods, we had a daily download of the cases. They were given to the pod leader, who put it on a Google spreadsheet, and then people took their cases from that Google spreadsheet, found the phone number, contacted the case, found out who their contacts were, completed a form, uploaded them, and this was all put into the information system that we have through the Single Patient Viewer, and hence that is how we are able to draw those maps and the hotspots that you have seen with Mary Ann. With disaster management, they have managed the whole isolation and quarantine facility. I mean, these are largely in the past been people, or let me go back, who who have done mountain rescue, droughts, floods, and that kind of person. So it's been a real learning curve for everybody. So now we're really in the third phase of the epidemic, where we've got a widespread community spread, and we have also hospital transmission. The case and contact tracing continues. The issues that we started facing were how to deal with returns to work, and in fact we found we had conflicting policy. Our policy in health was no more symptoms, your 14 days are up, you can return to work. Whereas the Department of Labour was asking and put out regulations to say that when you have done your 14 days, you need to be certified as negative, and therefore the employers were demanding that and this included many of the supermarket chains and also the police, that people produced evidence that they were no longer positive. So there are issues about conflicting policy which are still unresolved, although we've been told that it should be resolved in the next while. Then we also moved from the highly centralized way of doing case and contact tracing to decentralization to the substructures. So you may remember that there are 4 substructures in Cape Town. There's Khayelitsha and Eastern, that's grouped as one. There's Klipfontein and Mitchells Plains grouped as another. Tygerberg and Northern as another, and then Southern Western, which has a very strange configuration. It starts in Simon Sound and it ends in Atlantis, inclusive, and it's just along the stretch of the mountain. So we're busy decentralizing this to substructures and rather supporting the substructures. And it's a very uneven process as people get familiar and get confident and set up the workflows to get themselves going. We've had health workers who have been infected, and many have, and not many, a few have died. We've had clusters at many facilities, many of the hospitals, some of the community health centres, and they've had to close for cleaning. They've got to screen and test their close contacts of cases, and then there's a protocol for all the contacts as well. So it has been a disruptive time for the hospitals because of this as well. The hospitals with the ill cases and deaths, they've had to manage deaths, funerals, and no home visits. It's challenged the occupational health world as well, because we've had to. Usually we say that we are going to personal protective equipment isn't the first port of call. So having masks isn't the first port of call. You've actually got to change the system so that people to do away with the hazards that might cause infection. So protecting from the hazards. So setting up separate spaces in facilities for people under investigation. Different signage for the movement of patients and for access control to facilities. We've also had to set up and be proactive about support for staff, mental health issues, as well as transport for staff. Can't send them on the normal transport routes. We've got to protect our staff. And then finally, the PPE for staff in the various situations with N95 masks, with surgical masks and so on. So now we are having a widespread epidemic in Cape Town. It's not only because we have tested more by unit population, or because we were more targeted looking at clusters. Our death rates tell a story. We've got far more deaths, and I think that says that we've actually got a bigger epidemic. So our conundrums currently are, we've still got a huge backlog of cases that we've never been able to contact. We've got over 3,000 people that were never contacted because we ran behind when we got these big outbreaks and big clusters. Currently, how we've managed that is that from about 2 weeks ago, all people who had a test in the public sector through NHLS are being informed by SMS that they tested negative. We are trying to get a system going from the NHLS to inform all the people who test positive. There's only one area, which is the Mitchells Plain District Hospital, who has an automated system for informing all their cases that they are indeed positive, and then we follow them up, but with a phone call either on the same day or the next 2 or 3 days. Our big other conundrum, we've got the specimens that can't be processed. We've got the 18,000 backlog. So how do we manage this thing? What do we do with the 18,000? And are we if we carry on in the same way we're going, are we going to be 20,000 in 2 days' time? So we are busy applying our minds to how to deal with the backlog. But it surely does tell us that the testing policy needs to change. We really need to test shift that and focus on the sick people, which will inform who merit admission to hospital, because that will inform, as Graham Meinke said, how one manages people that are being admitted in hospital. High risk people, the older people and people with comorbidities, should we're thinking we're moving towards that, prioritizing them, and healthcare workers. Others outside of this lot, we can't go forward with this kind of a backlog and a growing backlog of testing people with symptoms. It's not going to be feasible down the line. This is not yet official policy, but in the next couple of days we see this as going to be promulgated. We still, how do we manage contacts if we've got so many cases that we've not contacted? Should we be, if we're going to inform people by an SMS, should we be telling them that they must contact their cases and their contacts and telling them what information to give their contacts? They know who their contacts are. And we're moving towards, instead of us managing the workplace, that there's now regulations that the workplace must manage themselves. We don't have to any longer contact the workplace unless the person hasn't informed their manager that they are ill. And then the manager has a whole lot of obligations to inform the Department of Health what they're doing and inform the Department of Labour what they're doing. We're now starting to think about this managing the hotspots. I showed you that heat map a little bit earlier, what a hotspot looked like. And now we've also got to start thinking about managing scarce resources at the peak. How are we going to ration care? So in the next phase, we're now going to moving into level 3 lockdown, where people are going to be returning to work, returning to school. That means that we're going to definitely have more outbreaks and more clusters, and we're going to have further community dissemination. So our burden is going to be moving towards managing ill patients, and I know you can't really see this, but this is a notice that was a press release that came from the Department of Health to say that the pediatric wards at Groote Hospital are no longer at Groote Hospital. They've been closed, and all those patients have been moved to Red Cross, and that space is going to be used as COVID wards at Groote Hospital. So we've had to think, on the spot and make reasonable decisions for the way we can use the available resources. Now we're also going to be managing hotspots. So the messaging, this means messaging. And the part of the thinking is that we should say everybody who's ill must stay at home. People must physical distance. Always use a mask outside the home. Hygiene, hand washing, sanitizers, and we need to protect the vulnerable being the older people and people with comorbidities, and those are the people that are going to be eligible for testing. So the hotspots strategy is still in evolution. The idea is to reduce the transmission of COVID in areas that have got are highly dense, and the hotspots really are informal settlements in and around Cape Town, ranging from Imizamo Yetu to Masiphumelele to Dunoon to areas within Khayelitsha, to Brown's Farm and those sorts of areas. So the idea would be to reduce the transmission of COVID, to try and harness collective efforts of stakeholders and communities themselves, with messaging prevention, which are these ones in blue up here, mobilizing community structures, and focus in on old age homes and high-risk people. And this is going to be run by a head of department from the provincial government. So not necessarily the head of health, might be the head of land or the head of education. That's the plan going forward. So the areas for intervention for Dunoon would be to manage the cases, to quarantine and isolate, to make sure that there's compliance with policing, but slowing the spread with behavior change and all these staying at home, physical distancing. It's going to have a big focus on humanitarian relief and food security so that we can all recover and get back to the lives, not that, and they will never be as we had them. So,
sorry, Virginia.
Yes.
Virginia, sorry, there's just a few panelists who may need to leave a little early, so would you mind maybe wrapping up? Sorry, I haven't been a very effective chair the whole afternoon.
Okay. So this is just a perspective of the hotspots. And so, okay, what have we learned? I think a crisis always upends the way we work, but we've seen that information can influence strategy and operations, and it really has, having the information that we've got. We've also got a new head of health and a new chief operations officer who've been open to new ways of working. I must say I found that the humanity and solidarity of people has also been astounding. The careful colleagues who've never been met, the volunteers who often, some of them are retired academics, have windows into vulnerable people's lives and have been really moved by that and have taken action about that. And the cases we've never met who've appreciated the care. We've had people wishing mothers happy Mother's Day on Mother's Day, because we work 24/7, so it was on that case. And the health services we have shown can be nimble. The stakes are high, though, if we don't make decisions quickly. So the challenges, and just as my last slide, I think I'm not going to show anything more, thanks, Misha. Are we failing because we've got this huge epidemic? No, I don't think so, because we've got to remember that the drivers of the epidemic are in Cape Town, as in one academic put it, is what is driving the transmission correlates with the density per square kilometre, and I think this is very true. Where people aren't able to self-isolate or social distance, that's where we have the epidemic. We do have much lower numbers of deaths, probably because of our more youthful population. Concerns, we've been raised before. Other health conditions, people are afraid to present, they're running out of meds. Challenges are going to be working with the private sector. We worked early in the epidemic with GPs and the laboratories, but I think that is still a challenge. Flattening hierarchies of ways of working are a challenge. Of course, this is a hugely expensive enterprise, so getting the money for that. And I think many people have been going for nearly 3 months, and there's a certain amount of exhaustion that's set in. Okay, I'm not going to continue. I think that's enough. Thanks very much.
Thank you very much, Virginia. That was really a wonderful overview of the outbreak response and the broader public health perspectives. Ladies and gentlemen, I must admit that I've not been a very effective chair, so I didn't stop any of our presenters as all their talks were extremely engaging and the students have been asking many insightful questions, so I allowed everyone to continue. But our ICTS team have kindly agreed to extend the time to allow our panel to speak. So I'd like to bring in our panel, and as I mentioned, we'll start off with our final year students who were part of the case and contact tracing team that Virginia has described so nicely earlier this afternoon. So I'd first like to bring in Sibusisiwe Mangotwa. Sibusisiwe, some reflections and any questions from you?
Hi everyone, I hope you can see me.
Yes, we can.
And hear me. Okay, great. So I've spent a few weeks helping out with contact tracing. I think for me it was a really valuable experience. I think I was looking for an opportunity to help out in some sort of way. So I'm glad that I could have helped in any way possible. I think what I've also just appreciated from the presentations from today is addressing the testing policy, which I also found quite a challenge when speaking to contacts particularly who were asymptomatic or well and wanted to get tested. And I found that that was a real challenge explaining the testing policy to people who didn't understand why they can't get tested, given that they've been in contact with someone who was positive. So I think that was quite a big challenge. But I think with much education and actually just speaking to the different contacts, I think that message carried across. I think my question would be regarding the workplace clusters, especially now as we're de-escalating the lockdown and more people are going back to their workplaces. My question would be surrounding what, in analyzing the clusters that we've seen already in the workplaces, what measures or what things put those workplaces at risk of being clusters or having all these cases? Because I'm sure most of them were wearing masks, they were doing the hand hygiene. So are there any additional factors or anything that we picked up actually influenced these clusters forming? And what can we do to actually prevent that as more people go back to work?
Thanks, Sibusisiwe. Virginia, would you like to respond to that?
Sorry, I lost. I was catching up with emails on my pod. Sorry, I missed the question.
Okay, Marianne, were you able to hear?
Yes, I was.
Okay.
Can you hear me?
Yes. Do you want to put your camera on,
Yeah,
Marianne?
so I think this has been a steep learning curve for all of us, including the workplaces. And as we discovered these workplace clusters, the Western Cape Department of Health, in collaboration with a number of occupational health experts, has put together a set of workplace guidelines, which it might be helpful for the students to have as a resource. And a number of workplaces have actually tried to implement these guidelines. I actually went to go and visit one of the factories in my new role as an occupational health person that Virginia talked about. And I think finding their first cases gave a lot of people a huge fright. And there's often, I talk about it as initially kind of people being too relaxed and then changing once they get their first case to a state of complete panic and not really knowing what to do. But we have found with a number of the workplaces that, in fact, engaging with them, they are very concerned around not contributing to spread and putting measures in place, such as really, good social distancing. But I think the extent, obviously, to which this is achievable in different settings and the actual implementation is going to be telling as we go forward. And I think what's going to be very challenging is it's easy to do this in the short term, but to actually maintain it in the long term and to learn to live differently, as Graham reflected, is going to be very difficult for all of us.
Thanks, Marianne. Maybe this is a good place to also bring in Yamanya Tembo, Dr. Yamanya Tembo, who's a public health medicine registrar who was also involved in the response. Any reflections or questions from you, Yamanya?
So maybe just to also add to what Marianne was saying, and to answer Sibusisiwe's question, a lot of what we found with workplace clusters is that people are comfortable with people that they know. So even they're doing the social distancing, wearing their masks, washing their hands. When they get with their peers and friends, they tend to let their guard down, and so they're not as vigilant. They don't socially distance. They share bottles of drinks together, and they don't watch the things that they're touching and how whether they're touching their faces as well. So I think those are some of the things that made workplaces more vulnerable to the spread of the disease. And I think some of the other things that we have learned also, as Virginia had said in her presentation, was just learning to be agile. I think is one of the things that I'm taking from this experience. Looking at your data constantly and changing your approaches based on what you're seeing, and also being fearless, I think, because not everybody thinks the way you think, or not everybody would have looked at the information that you have looked at. And so being fearless in putting your point across and backing that up with evidence to say, this is what I have seen, this is the data, and this is what I think we should do based on this data. And with that, I've noticed that we've been able to move some of the conversations in the public health space to change some of the ways that we have been doing things. For instance, even the testing strategy that we were using initially, we were missing quite a number of cases because we were only focused on people who have traveled outside the country and those who are symptomatic. But when we were looking at the data, we saw that we were missing cases who are ending up in our facilities as admissions and who had previously not been tested because of our limited testing strategy. So just being, fearless to say, this is what I have seen, this is the data that backs my assumptions, and, keeping on persisting with to get your message across. And also that change is, a difficult process, and we're still in this current scenario, which is really stressful. And we've had to change several things over the period of weeks, put out different policies, and so I think it's been my learning that you need to constantly have these discussions, have open doors, collaborate, ask for help in trying to bring about change. So even in the workspaces, as you return to the facility, make sure that you keep on trying to practice the things that you've been reading about. It's not going to be easy to always wear your mask, to always remember to wash your hands, but to try and remember those things, and with time it will sort of stick, should I say. Yeah.
Thank you very much, Yamanya. That was very insightful. Maybe to link in what Virginia, Marianne, and Yamanya have alluded to, but linking that to the clinical side. Graham, one of the questions that the students mentioned is, how do cases at home? So, Virginia talked a lot about people evaluating people from a computer and that change, but how do cases at home monitor subtle signs which can lead to quick deterioration, such as silent hypoxemia? Any thoughts on that, Graham?
Yeah, I'll answer that question, but I just want to emphasize a point that Yamanya has brought up, and it's about people letting their guard down with respect to prevention practices, and it's something we saw in hospitals as well. It's not just in non-medical workplaces, is that medical staff and nursing staff would take great care in the ward with PPE and hand washing and all the practices, and then we'd go into the tea room or the meeting room and crowd in the room and gather together with no thought of prevention. And I think it's a subconscious kind of cognitive bias that people were initially thinking, we're at risk from the patients and not from our colleagues. And there was a number of transmissions within hospitals between colleagues and outbreaks that were not related to patients, but healthcare workers bringing it in from the community and spreading to other healthcare workers. So I think that's something that students need to be very alert to, is this kind of bias that you think that the danger is in the ward. The danger of COVID acquisition is everywhere, and that precautions need to be practiced everywhere. In terms of your question about home monitoring, really, there's very little science that's informing us. We know that the majority of people who go home, who are assessed as having mild disease and go home, will do well at home. There's a subgroup that will deteriorate and develop a pneumonia, and we can only say to them in our setting that if you experience breathing difficulties, then come back to hospital. And of course, there is the risk that some people will come back profoundly hypoxic, and we've seen that, and people needing to be intubated in the casualty unit soon after arrival. And there might even be people who die at home because they just delay it too long. But I think that our experience is the majority of people do come back when they've experienced pneumonia, and the majority are admitted. They need some oxygen support, and then they deteriorate further in hospital. But there's really, in terms of the issue of silent hypoxia, that's a difficult one. We can't afford to admit everybody. I mean, it's just simply unfeasible. And as I said, the majority of people will perceive their hypoxia in our experience and come back in time.
Great, thanks very much, Graham. I'd like to bring in one of our other student panelists now. Christine van der Walt, any reflections and questions from you?
Hi, so I also worked as part of the contact tracing team. And I think a reflection for me from that experience was that there's constantly new information coming in, and it can be quite overwhelming to think clearly and change the strategies that the contact tracing team was using. And I think also, especially in communicating to patients, to cases, just that when advice changes based on new information. And I think my question, Yamanya touched on it a little bit, is what were the challenges and the learning points for all of you as experts in trying to communicate new information, and also taking in all this information and thinking about it clearly?
Thanks very much, Christine. Challenging question indeed. Maybe should we start with Virginia? Virginia, just unmute. Yeah, there we go.
Yeah, I think it's at one stage in my life I was an organizer in a youth organization in the Catholic Church, and I used to do recruitment and organizing people into groups and things like that. So it brought a lot of this was over 40 years ago. It brought those skills back to bear on the work that I did with recruiting people for the work pods and for at UCT. So I used all that sort of memory of and ability to pull things together, and it was quite amazing. I had forgotten that I had those skills.
Thanks, Virginia. Graham, any thoughts from you? Graham, just unmute.
In terms of integrating all the new knowledge?
Yes.
Yeah, it's been very challenging. I mean, I think there's probably been 10,000 papers published on COVID in the last 3-4 months, and a lot of it is very poor quality science, and so one has really relied on colleagues and trusted people in the field to direct one to what's important, and so I think one needs to realize that a lot of it is not relevant, important science, and I think having journal clubs, having department meetings, finding out what the important papers are, what the ones that are going to influence practice are important, and that, I mean, even using social media, Twitter where some of the looking at reliable sources of information like the journal websites and leading infectious diseases researchers around the world, following them and seeing what's important, I think helps one to focus one's reading on the high impact important articles, because clearly one can't consume everything. And then we've, on the clinical side, I mean, it's been a very steep learning curve, because I think, you know, what students must realize is this is a completely new disease. It's you know, we can't, there are obviously some lessons that we can learn from other diseases, other pneumonias, other infections, but the way it's affecting organ systems and the pathology, and, you know, I alluded to it, the way in which patients present with profound hypoxia, but some of them we can prevent the need for ventilation. All of those things are things that we're learning and having to make very difficult decisions, because there's no blueprint to work from. But I think working with colleagues, having discussions around the bedside between, you know, an expert in critical care, an expert in pulmonology, infectious diseases colleagues, you know, making these decisions together makes it a bit easier. And we know that because nobody knows exactly what's right and wrong, we're going to make some mistakes, but we just know we've got to give it our best kind of input in terms of thinking through what the issues are and then making a decision and learning from the decisions that we make correctly and the ones that are incorrect.
Thanks, Graham. Marianne, any further thoughts on that question from you?
I think the one thing that's been very important is learning to live with uncertainty. I've been working a lot in the space around modelling, and everyone's been terribly frustrated that we can't come up with a number of what to expect. And in working in that space, realize that there's so much that we don't know about the disease, which is why it's so difficult to come up with a number, and have found in particular that kind of they're almost in a hyper accelerated way, these kind of waves of information. There's suddenly a whole wave of information around. Maybe far more people have actually been infected than we think, and the proportion of asymptomatics is really high, and then the next wave will come and the serology studies will come out and say, actually, no, the proportion infected is not that high. So I think a bit of healthy skepticism has also helped, and as Graham says, speaking with colleagues and being directed to the better science or the good science that is out there. And then I think when I think back to the late 90s and how hard things were then with HIV, one of the things that saved us was working in teams and supporting one another. And I think that is what is going to save us again. And we've seen it again. People have reached across silos. They've reached across institutions. They're not necessarily following the normal referral pathways. They're doing things that they're not normally allowed to do. And that is what is going to help us in this time and help us to learn faster, which is what we need to do.
Thanks very much, Marianne. I'd like to bring in Danielle Hugo, who's another 6th-year student who's been involved in the case and contact tracing teams, to give us some reflections and any other questions. Danielle?
Thank you, Dr. Jacob. I'm sorry, my video is not working, but can you hear me?
Yes, we can hear you. Thanks, Danielle.
Thank you. So I've been involved in a few things over the last few weeks, and working at the Department of Health with case and contact tracing, I've really come to appreciate the unpredictable nature of the pandemic and been fascinated by all the public health decision making, and had some really meaningful interactions with patients. I've also been involved with Shawco Health, working at the Strandfontein site for the homeless, and seen firsthand how politics and bureaucracy can provide daily challenges that are often equal to those related to COVID. I've also tried to help with some of the online resources for more junior students and been inducted into the complexities of online learning. I've also really enjoyed tuning into the Department of Medicine webinars, and it's been really comforting to hear from all of our FHS celebs and get first-hand up-to-date sort of information. And I know a lot of people in our class have really poured their hearts into these things, and I mention these specifically because I think that in light of all this, it's been really sad for me to hear some of the assumptions by superiors that students are inflexible or impatient, or perhaps most upsetting of all, uncaring. And I personally have a lot of fears about returning to the clinical platform, and all of them stem from a place of caring quite deeply. And with that, I reference specifically the article shared with us on the ethical duty of healthcare professionals. And I really hope that we'll be able to move forward in a more collaborative manner that fosters respect between sort of faculty and students alike. And I think that platforms like these webinars give us an opportunity to do so. And I'm really grateful that during this course we've been able to engage more and be brought into these discussions. So I hope that moving forward in the clinical platform we can build on this and and really work together, because I think that we have a lot to give and a lot to learn. I hope that sort of these things are taken seriously and that we can continue to have a voice in the process. So thank you very much for that. And also, my question was also about healthcare worker cases, but I think it's been addressed in the presentation. So thank you so much to the speakers for giving us such insightful presentations.
Thank you very much, Danielle. That was very insightful. And I think we must definitely applaud all the student volunteers who've come on board in many different ways. It's really been inspiring to see the passion and the dedication that many students have been showing. And, you know, we do live in uncertain times, lots of different attitudes, opinions, etc., that sometimes cloud the way people respond to situations. And we recognize that I think many of the speakers have alluded to these uncertainties and the anxieties that we all face. But thank you for that very profound reflection, Danielle. I'd like to just give our speakers one more opportunity.
Can I just respond to?
Absolutely.
You know, clearly, there's a lot of information going around, but I just wanted to say to Danielle, you know, I've been speaking to colleagues a lot across the clinical platform, and you know, the feedback that I've consistently got from doctors working, you know, at both Groote and the peripheral hospitals like Victoria and Mitchell's Plain, is they are very excited that the 6th years are coming back onto the platform, and that was, you know, a spontaneous response when they heard that the 6th years were returning. They are looking forward to teaching. One of them said it'll been a break from having to deal with COVID day in and day out, and so they're excited to engage in teaching and also to have your contributions within this time in the service. And I think that students can make an important contribution in the clinical service, but at the same time meet their requirements in terms of the clinical teaching in the 6th year. So, you know, I really want to convey that, and at the same time say that, you know, students, I think you need to also be cognizant of that the clinicians are under extreme pressures at the moment, and you know, if sometimes people behave a bit irrationally and aren't quite themselves, just be aware that the doctors are under extreme pressure, and so just be patient with your teachers in that way as well. But I just wanted to give that feedback that people are excited that the 6th years are returning, and thank Danielle for advertising the Department of Medicine webinars, and just so that people are welcome to join that. It's 4 to 5 p.m. every Wednesday. Tomorrow is actually 5 to 6 p.m. as an exception, but the link for that should be available through the Faculty of Health Sciences. So thanks.
Thanks very much, Graham. And I think that's a good place for us to conclude today's webinar as well. So I'd like to just say a very special thank you to our presenters and our panelists for an excellent discussion on very pertinent issues. Thank you for what you're doing. It's not easy being in the different positions that you're in, and we wish you strength for your continued roles in this outbreak response in different ways. And we really appreciate you. And I do apologize that we went over time, and I'm so grateful that you were all able to stay on and still respond to questions. Our students have given us some very insightful questions, and we'll continue to try and respond and post the answers on Vula so that those who were not able to connect can still see and engage. And I'd also like to say a very big thank you to Olga Sekwari, Clint Oliver and their team from ICTS for all their technical support today. And lastly, I'd like to thank our students for all their insightful questions, their engagements over the past 2 weeks in this course. I hope you found this session useful and that you found the course useful to engage and think about different aspects of the pandemic response. So all the best for your OSCEs and your return to the clinical platform. We are here to support and guide you wherever possible, so please feel free to reach out. Take care and stay safe. So we're going to cut the live feed, but if I could just ask the presenters to stay on just for a few minutes. Bye, everyone.